I'm Dr. Seth Rosenzweig, and there's been a slight change in the program today. Dr. Andre Sanak initially was going to be the presenter, but as surgeons, our schedules do change last minute. So we did a tag out, and I took today's session, and most likely he'll pick up another one of these educational seminars later down the line, maybe in January or February. But you got me today, and I'm part of a larger group known as Louisiana Orthopedic Specialists. We're a orthopedic all-fellowship trained group. We're the leader of sports, spine, and orthopedics in the Acadiana region, and I do have an office in New Iberia, and while most of my partners are in Lafayette or Eunice. So when people think of joint replacements these days, they aren't thinking of using a cane or a walker. They want to move like this. And this is one of my patients I did a couple weeks ago, and he forgot his walker, and so he just jumped up to the second floor. But in reality, it's not quite that dramatic. This is a more reasonable expectation. This is a 6-day follow-up, real person after a hip replacement, and you can see smooth gait and unassisted, and that is a reasonable expectation. But today, we're going to talk about a new technology that I think you will find will help us get you to that jumping to the second story. And the orthopedic service line, myself and 2 other orthopedic surgeons here in New Iberia, including Dr. Lasecki and Sanak, we are the first robotic-assisted surgical program in the parish. And we're doing this in partnership with Iberia Medical. And we've brought this to the hospital around January, February of 2020, right when COVID was hitting. But we really did not miss a beat and really picked it back up in late March, early April. So we've been doing this now for a good 12 months throughout 2020. And I think you're going to find the way I talk about it, the results have just been outstanding. And that's a picture of what the robot looks like. And when people hear robots, they sometimes get scared. And we didn't go to the future to get a robot to come over and take over mankind. That's not what this is. And the robot does not act on its own. It's not an android. It doesn't have artificial intelligence. It is programmed to do what we program it to do. So what this really is a combination of high-level computing, guidance systems, and computer-aided technology, where we can model individual patients' anatomy and then program the best surgery for them. And then you combine your surgeon with the aid of a robotic arm, and that's what the MAKO technology is. And this is an example in the operating room, and these are 2 knees I was doing. You can do a total knee, a partial knee, as well as a hip replacement. Here's the hip replacement. And we've done all of these to great success so far here at the hospital in New Iberia. And why is this so important? Well, I think you'll find that as we go from 2005 to 2010, all the way to 2030, every 5 years, we're doing about 500,000 more joint replacements. So that's, by the time we get to 2030, 3.5 million people. So we better be doing these well, we better be doing them right, because more and more people will be having them. And if you look at the hospitalizations related to arthritis, you can see that just in 2010, and that's what this data is from, we had 1.5 million, most likely hip, knee, and shoulder replacements, compared to the heart attacks, the strokes, and the breast cancer. And you can see arthritis dwarf those 3 combined. And we're putting these joints not just in the elderly. And it used to be you had to be over 70 years old to get a joint replacement, but that's not the case anymore. And when we look at the cartilage, and that's what arthritis is, it's disease of cartilage. Cartilage is the soft, spongy, watery substance at the end of a bone in a joint that gives it the cushion. And when we get a little older or have some other process or injury, we can get wearing away of that cartilage. Same thing in the hip. The other was a knee example. This is the hip. And I tell my patients, think about it as a tire losing its tread. That's what arthritis of your joint is. So when we diagnose this, usually I can pick this up from a story you tell me. My hip started hurting. It's only when I do certain activities. And then the x-rays are very crucial. You can see on the x-ray on the right of the screen, bone on bone. Same thing with the knee, very similar example. The one on the left, lots of space. The one on the right, bone on bone. And knees are a little easier to see arthritis. Typically they come in different shapes, either bow-legged or knock-kneed, and we call that varus and valgus. And the hip isn't quite as obvious. You can't quite see the crooked hip as well, but patients typically will point to the same spots, more of the groin region, more of the buttock region, more down the side of the thigh. And those are some more hip related pain variations. So we typically do start non-surgical. Just because you go to an orthopedic surgeon's office doesn't mean you're leaving with a packet for a knee or hip replacement. We do try and maximize conservative management. Some of those being a cane, a crutch, maybe even heat, cold, and therapy. Strengthening around a joint is a very powerful way to try and stretch the flexibility, but also strengthen and take the stress off of that joint. And we do have medicines, anything from Tylenol to anti-inflammatories to steroids. And many of you have heard of the rooster comb injection, which is a joint lubricant type injection, which is approved for the knees, but not the hip. But weight loss may be the hardest thing for us down here in Louisiana to do because we have such good foods, such fatty foods, rich in carbs. But we do know that just losing 12 pounds can take up to 30% of your symptoms away off the joints. But there may come a time when you do need surgical intervention. You've done everything we've asked. You've done all the conservative management. And at this point, your activities of daily living, the things you like to do, they become difficult and you want to change. So at that point, it may be time for you to talk to an orthopedic surgeon. Now, we're talking hip today, and I want to show you the premise of a hip replacement. And there's lots of different ways to get into a hip. There's the anterior approach. There's the lateral approach from the side, and then there's the posterior approach from the back side. So one of the approaches I like to do is called the anterior, and this is where the patient's flat on their back, and I actually go between the muscles, not through them. And the concept is we take that worn out ball and socket and we replace it with material that is smooth so that we're taking away the square peg in the round hole and we're putting in the round hole and the round bearing in the round hole. And you can see from this example, that's the premise of the hip replacement. So what's improved in the past 50 years? Well, as technology improves every decade, the implant designs, the materials, they last longer and longer. At one point, we're trying to see how small of incisions we could put these in. Shorter stays, going home the same day. That is nothing new now. It used to be a joint replacement was a 7-day affair, and now you go home a couple hours later, potentially. And we're so much better at improving the pain control. We've learned a lot of new techniques and blood loss, minimal blood loss. Transfusions used to be a 30% incident with joint replacements. Now it's less than 1 to 2. So the question always remains, have we hit that end point where we're perfect? And I would tell you, we probably aren't quite good enough just yet. So one of the founders and the fathers of hip surgery in the world, Sir John Charnley, he was British. And like a lot of our innovators, he came around World War II. And he didn't initially get into joint replacements for arthritis, but more for tuberculosis, which used to be a huge problem in the modern world. And he basically started a lab in his garage, and his fascination and his interest and expertise were in how does lubrication of these metals and plastics interact with the human body. And so the original hip replacements were Teflon, acrylic, and cheap polyethylene. And they did okay, but high failure rates, lots of complications. And so over the past 50 years, we've learned how to maximize the materials. Not only now do we have polished materials, but we have these grit blasted, 3D printed. Some can grow into the bone, some can use cement, but the shapes, the designs, all meant to maximize improvement in the human body. And the same with the sockets, the acetabulums. It used to be we cemented in a piece of plastic, and now we have these really high-tech materials that grow into the bone. You can certainly still use plastic. We use all kinds of different bearing surfaces, from cobalt chrome to titanium to ceramic to metal on metal. And similarly to the knee, when we put in a hip replacement, there's a concept behind it. We're trying to achieve certain numbers, engineering principles, physics. But the pelvis isn't a two-dimensional structure, okay? So when we're doing these surgeries, we have to recreate the 3D anatomy. We have to recreate that socket that patient has, the femur that patient has, because a femur just isn't straight. it has bows, it has bends, it has offset, which means the distance from the circle to the edge of the hip. All patients kind of have variations. And so you really can't have one parameter for every patient because we're all just a little different. Okay, and so this is a good looking x-ray. This looks like a good result. Can we achieve this every time on every patient? And ultimately, that's the goal. And I would tell you, are we there yet though? Are we doing this? Because if you don't position in a certain parameter, problems can happen. Hips can pop out of socket. And that's a known complication of hip replacements. And we think that there's a better way to put these in so that that doesn't happen, but are we doing it every time? And will putting the implants in maybe not perfectly lead to early wear and failure? Meaning that if there's increased stress because maybe the angles aren't quite right, will that ball that you're looking at wear through the plastic in that cup, and the little material, the what we call osteolysis, meaning the materials that are being worn, they start to erode through the bone. And if you look at those yellow arrows, you can see the shadow there where the bone is being eaten away. And lastly, if we put these in not quite perfectly, will they bang on each other when people are trying to sit or move or bend or lunge? So we think that there are some parameters that we need to achieve. And some of our legends over the past 30 years, from Dr. Lewinek, Ranawat Dor, they've helped teach us if you put your socket in this certain angle, if you put it in a certain tilt, if you put your thigh component in a certain way, we think you'll achieve better motion, better results, longer longevity of the implant. So how do we get there? How do we get to this x-ray every time? Well, right now, we take an x-ray, which is a 2D measurement of the patient, and we bring out our stencils and we start planning the case. And this is done often where we go to the operating room with a 2D plan for our 3D patient. And we determine how long we're going to make the legs, where we're going to make our cuts based on 2D data and x-ray. And when we perform the surgeries, do we know exactly where the patient's pelvis and hip are at all times? Because part of the premise of this is we're making measurements based on where we think the pelvis is. So when we do these surgeries, sometimes we put a patient on a pad like this, but do they move during the surgery? Are they really like this or like this? And are they not as straight as we think we are? And once we do our draping so that we have a sterile environment, you don't know if that patient maybe fell forward 5 degrees or tilted a little bit. So we do have some mechanisms to protect against that, but most of them are handheld and using the surgeon's eyes and judgment to see if the measurements are still correct. But there is, I think we all know, there is some human error involved with that. So I would tell you that when you look at some studies, we would say 50% of patients we do hip replacements on probably don't have perfect positioning of their components. It doesn't mean they don't have a great result. It doesn't mean that they don't love their hip replacement. But if we're being critical as surgeons at ourselves, saying, did we put this in exactly how we wanted to 1 and 2 times? In some of the papers, surgeons would say, no, I did not put in the perfect hip replacement. So we know humans aren't as precise and accurate. And what that means is if I'm accurate, that means I can hit the bullseye. And if I'm precise, it means I'm going to hit the bullseye every time. And obviously, when you're doing surgery, that's what you want. But let's look at some other fields out there. If I were a baseball player, 30% of the time, if I hit the ball, that's considered a Hall of Fame career. In basketball, if I make half of my shots, I'm a Hall of Famer. And in the NFL with Drew Brees, he makes 65 to 70% of his passes, Hall of Famer. But as an orthopedic surgeon, if I'm only 90%, I'm probably out of work. So how can I get better? How can I get more accurate, more precise, so that the hip replacement I think I'm performing is the one you're getting? Well, let's talk about the MAKO technology from Stryker, okay? It is those things I was alluding to earlier with the computation, the guidance, and the robotic arm, with the automation, the navigation, and what we call stereo haptics. That means the robot and the computer knows where you are at all times in space, so that when we're performing your surgery, if your body moves 5 degrees, the robot and computer adjust for that. Okay, here's another picture of the robot. It doesn't have a head. It's just a hand control device that's linked to the computer. And the concept is you know more. The beauty of this MAKO system is we're constantly getting data from the computer about your measurements, about your lengths, about your angles, so that when we go in to execute the plan, we're doing it one time. We're not erring from that plan. Now, this is just a knee example. This is really, I'll have a couple of knee slides, but they do a good example of showing the software, because you can see there's a model, and this is a specific patient's knee, and we're able to actually model the implants in, how we want to put them in, the angles. And the 3D model is taken from a CAT scan, and that's a very important part of this. We get a CAT scan in addition to the x-ray, and we map your anatomy to under a millimeter. So I know every nook and cranny of your knee, of your hip, so that we know exactly what we want to achieve and how we're going to achieve it. And then obviously the stereo haptics is what I was referring to. Is once you start to execute the plan, if you try and deviate from it, go outside the boundaries, the robot will shut off and will not let you color outside the lines. So even after you've done all of this, you can even then test the implants. You put your implants in, and then you do a check saying, okay, am I balanced on each side? Did I achieve the length, the offset, the inclination? All of the numbers important to us as orthopedic hip and knee surgeons, we can see real time. Now let's go to the hip. That's why we're here. And this is a small video put together by Stryker that I've borrowed. And we're talking about hip arthritis. Remember, you've worn the tread off the tire. Okay, so we have square peg, round hole. So how do we best correct that to get the smooth ball in the round hole so that it's nice and smooth, so you can go back to all of your gardening, your fun activities. And so we're seeing the model here of the hip application. And in this case, this would be considered a lateral or posterior approach. That's not the anterior approach for this model. And you can see there's a device there at the end of the robotic arm that helps you place in your socket and prepare your socket. But first we get our CAT scan, because I have to model your hip. I don't care that it's somebody else's hip. I need your hip. So we're going to model your hip. And then we go to the software and we start talking numbers here. And you can see I can move this into a 3D orientation. I can start modeling how I want your implant to look, exactly how I want it to be, so that when we come to the operating room, not only have we designed the plan, but now we will execute that plan to within a millimeter, to within a degree. And there's a lot of ways that that happens. And part of that, you see, we map your anatomy. So the robot knows what it wants to do, but then I have to show the robot and computer, okay, this is this person's anatomy. So we map several points and we verify them. The socket, the femur, the bone, every little place that the robot says, I need more data, we give it to it. And we can't proceed until the numbers are crunched and we're verified. So you're never going to have a chance to inappropriately do this if you follow the protocols, which the robot makes you do. And then you bring in the device, and we need to fashion a socket. And let's say I said I want a 40-degree socket with what we call 20 degrees of anaversion, which means front to back tilt. The robot will help me bring that in. It will not allow me to vary from that, and it'll actually even help me go to the depth I want. So we're putting these in now how we think we're putting them in. Just because I planned it perfectly doesn't mean I can execute it perfectly, but now with the MAKO technology, we can. So we're eliminating a lot of the human error. We're using a lot more verified data to do a more precise operation. And so we're hoping these things will improve outcomes, blood loss, motion, dislocations, satisfaction. So we've been using this now for the better part of 4 to 5 months here in New Iberia. We've been using the knee application for the 12 months. And I would tell you the data that your surgeon can get is unmatched at this point. Before we did this with the eye test. And you know, I like to think I have some pretty good eyes, but realistically, now anybody in my hands can be the $6 million patient. And this was somebody that had to get to their car after their surgery, and they didn't want to wait for someone to bring it around. Actually, that's Lee Majors, if any of you guys remember it from the 70s and 80s. And he was half man, half machine, which I say all my patients can be now. So the MAKO robotic arm assisted surgery has been around for almost 15 years. And this data is almost 3 years old. So I would tell you at this point, probably 250,000 MAKOs have been performed worldwide. In Louisiana, there's over 15 robots at this point. Just in the Acadiana region, there's several robots. So I think you're going to see this technology, much like when we revolutionized the industrial age of the early 1900s. Once this technology gets here and shows us the efficiencies, the precisions, the accuracies, it's hard to argue that we shouldn't at least be exploring something like this. And I'm not saying every patient has to have a robotic surgery, but I think the data involved in the verification is important. And with the MAKO system, I'm able to do those things for my patients. So it's really a unicorn, as I call it, because it does do hips and knees. But the one thing it does use 3D modeling. And I like that, because the 3D model really helps you rule out any variation in what the 2D X-ray might be hiding. It also helps you map so that I can really get the most precise measurements and the best data for my patient so they get the most accurate surgery. And then obviously the stereo haptics means the robot knows where you are in space. So if you were to fall 20 degrees off of that beanbag that you were sitting on, the robot would say, they've moved 20 degrees, we have to move 20 degrees. So that is another beauty of this technology. So are your doctors obsolete? And again, we are not, because we're the ones programming, planning, and using the judgment. This isn't Hal. He's not going to shut the bay doors on us so we can't get back in. This is really a combination of your surgeon using a high-end computer-aided technology with guidance, with stereo haptics, meaning it knows where the patient is in space, to achieve the most perfect joint replacement we know how to do in 2020. So for now, you're stuck with us. And at this point in the presentation, I'm happy to open up to a question and answer. We'll keep it open for a minute or two. And if nobody is able to interact or doesn't want to, you can certainly reach out to me through my office line, which is 337-235-8007. Again, I'm part of Louisiana Orthopedic Specialists, and we do offer the MAKO hip, knee, and partial knee application. Okay, thank you everybody for attending, and we're going to open up the lines now.